Welcome to Psych Incubator. Tonight we have a special guest, and tonight's program is going to be a little different. Tonight we are doing Psychotherapists Face-to-Face, and I'm going to have the pleasure of having a discussion with Dr. Connor Adams, who is a clinical assistant professor at Stanford University School of Medicine. Connor completed her PsyD at the George Washington University, did her internship at Harvard Medical School in Cambridge, and did her postdoctoral fellowship at Stanford University. Her clinical and research interests center on therapeutic interventions that support recovery for individuals living with serious mental disorders, and she's broadly interested in increasing access to person-centered and recovery-oriented care. Connor's interest is in psychodynamic perspectives as well as dialectic behavior therapy. So she combines a lot of different approaches and I think in an integrated way. She also enjoys supervising and teaching, including teaching an overview of modern psychotherapy approaches for Stanford undergraduates and first-year psychiatry residents. And also, which we're going to get to talk about, is she teaches a course on the Rorschach, which I think is really going to be fun to talk about because I think it's an amazing instrument, but that's really been underutilized in our field. So, Connor, welcome to Psychotherapists Face-to-Face. And I'm going to start out with asking you, what got you into this field of and like specializing in working with severely mentally ill patients, which I think is really going to be interesting for all our viewers.
Yeah, well, thank you so much for having me, Jeffrey. And in terms of what got me into the field, I sort of fell into psychology. I feel a little bit like it found me. As we were chatting before the recording, I was telling you, growing up, my father is a surgeon and my mother is an
What kind
interior.
of surgeon? Like
He is a
general?
hepatobiliary oncologist. So that means like liver, gallbladder,
Oh.
pancreatic cancer.
And where did he practice? Where did he do his
He's
surgery?
at UVA, University of Virginia Hospital, went from med school and has stayed on since. Yeah.
Interesting. So
Yeah. So
you had a medical sort of family that you grew up in.
yeah, so he's a surgeon, and on the other hand, my mom is an interior designer and is very much into the world of creativity and color and art. And mhm. And when I was a little kid, people, would ask, "Oh, what do you want to be when you grow up?" And I'd literally tell them I wanted to be an artist scientist, and they would chuckle and probably think to themselves that that's not a real job. But as I got into my own undergrad studies, I was just taking a smattering of random classes my first semester to see what caught my interest and happened to be taking Psych 101 and felt like that was the sweet spot. I appreciated the science behind it, the rigor of it, and also the room for creativity and exploration and not always knowing the precise answer. Um, just kept taking psychology courses, went to grad school. And as far as working with folks with more serious mental illness goes, it worked out that I'd done several different practicums in grad school, ranging from community counseling clinics to college counseling centers working with students to one in an inpatient hospital. And I just found that that was where I felt most energized, most excited. The work was certainly never dull. It was invigorating. I felt like I could really help people when they were quite scared or hopeless or frustrated or whatever distress was happening in their life. Um, and in the hubbub of the craziness at a hospital, of everything being so busy and nobody having time in the day, it felt really meaningful to be able to sit with people and learn about their life and try to offer help. And so I just kept doing that. And here we are.
So, wow, that's wonderful to hear that you have an interest in working with the severely mental ill, because as I kind of look back at the decades that I've been in this field, it seems like early on there were people who were interested in doing psychotherapy with psychotic disorder, people with psychotic disorders. And
Mhm.
then as the ascendance of biological psychiatry arose, it seemed like a confluence of forces resulted in psychotherapy kind of being put to the side and not many people
Mhm.
seeing the value or being interested in doing psychotherapy with people who had psychotic disorders or schizophrenic illnesses. Um, tell me a little bit about what you know from your research and from your scholarship about like what how
Mhm.
that happened and how we got to the point where now
Mhm.
in a lot of places I think people just go in for their visit with their APRN who prescribes or their
Mhm.
PA or their psychiatrist, and
Mhm.
they don't necessarily have access to someone like
Yeah.
you.
Yeah. I think it's multifactorial how we went from maybe the good old days of people getting really in-depth psychotherapy care in addition to medication and other more biological interventions to where things are now. I do think part of it is just the world we're living in and how insurance works, the number of beds available at hospitals. For a lot of external reasons, there's a pretty heavy pressure to discharge people quickly from
Mhm.
inpatient units. And there's not always solid outpatient referrals available, where theoretically somebody could have a really short hospital stay and then step down in their care to an intensive outpatient program or partial hospitalization and then continue to step down to outpatient treatment. But IOPs, PHPs, et cetera, are hard to make financially viable. So there's just not always good options. And in the pressure to keep length of stay short, the pressure then does fall on, okay, what medication changes are we doing? What new medications can we try? Get this person sort of set up with those things and then out the door. I think part of it too is that more recently in the field of psychology, there's been an appreciation for brief psychotherapy and has been more research, as of late, that even one session can be helpful and can have an impact, right? It might not totally change someone's life in a single session, but there is a growing appreciation that it's not useless. It's worthwhile, even if it is one time that you're sitting down with someone. I often think about on the inpatient unit that if I meet with somebody one-on-one or even in a group, if I have done nothing else than leave in their mind that therapy can be helpful, or at least isn't
Yeah,
terrible,
yeah.
so they're more likely to engage in follow-up care. Like I'm putting that in the win column. Um, but yeah, I think you nailed it, that there is this huge movement towards very biological interventions, and those are certainly helpful and necessary. And it was sort of an overcorrection in a way. And now I think we're swinging back toward the middle.
So I remember some of the research that I reviewed years ago that showed that there's a significant improvement in functioning and quality of life for people who not only are being appropriately pharmacologically treated, but also have ongoing psychotherapeutic a
Mhm.
psychotherapeutic relationship. That it was
Yeah.
really clear that on almost all metrics that the patient was doing so much better with having someone that they could meet with and form a relationship and talk to. What
Yeah.
are you familiar with any like current research on the combination of
Yeah. Mhm.
psychotherapy with pharmacotherapy?
Yeah, yeah. I don't know about like specific cutting edge research per se, but what you're saying is well established in the literature at this point that with psychosis and many other presenting concerns, having both medication and psychotherapy often is the most potent treatment. There's certainly situations where I find medication is necessary first if you are wanting to move beyond anything other than just like strictly supportive therapy. So in our outpatient clinic at Stanford, our early psychosis clinic, it's usually standard practice that if somebody is a new patient coming in, they will do an intake with the MD team, meet with one of the psychiatrists,
Uh,
and then they'll do an intake with the psychology team, usually in that order. And sometimes those appointments are more or less back to back. Other times they might be paced out by a few weeks or even a couple of months. Um, we do always encourage folks to do both, but sometimes because of particular symptoms or experiences people are having, some kind of medication stability can facilitate therapy, and therapy has a meaningful add-on to medication. Medication,
So a
yeah.
long time ago at Shepherd Pratt in
Mhm.
Maryland, which one of the leading
Yeah.
hospitals for psychotherapy, psychiatric treatment for all kinds of patients.
Mhm.
Melanie Klein, I believe, worked
Mm.
there, and
Mhm.
she pioneered work with schizophrenic patients. And actually, I think Harry Stack Sullivan, who was
Mm.
one of the pioneers in interpersonal psychotherapy, I think also
Yeah.
worked there. And in some of the research that I did, just digging into some of this
Yeah.
scholarly work about that, they did very intensive psychotherapy with
Mhm.
severely mentally ill patients. And
Mm.
unfortunately, there was a case that I think really kind of influenced the way the field then made took a different path, and it was there was a patient there that was clearly psychotic, I think schizophrenic, and they did not medicate and wound up committing suicide. And I think there was a lawsuit. It's a pretty famous suit, and I think as a result of that, that some of the pioneering people that were working with doing intensive
Mhm.
psychotherapy kind of, I think, got like frightened,
Yeah.
and I think we lost a lot of the sort of the um, benefit and the importance of the work that some of those people were doing to not maybe cure but to help heal. Uh,
Yeah.
so do you know anything about any of that early?
Yeah. I guess I have two thoughts about that. Of one, I think that is a real barrier to people getting into this work, or any doing any kind of helping profession with folks who have more acute illness, whether it's mental health, physical health, is this fear of sort of quote unquote bad outcomes or liability. I mean, of course, it's
Part of the work?
part of the work and extremely upsetting if a patient dies by suicide. Like, of course, people want to try
Yes.
to avoid that in their career.
Well,
And
but again, not again, but we're in a profession where it's
yeah,
like if your dad is a surgeon, if people came in and he said they're too serious for me to
yeah,
operate it because they might die, like how
mhm,
would that be? And I remember
yeah,
a long time ago when I first opened my practice, I had a psychiatrist from a hospital that I worked, and he would come and do pharmacological consults with my patients. And he
mhm.
came to me one day and said, "Jeff, I can't work here anymore." I said, what's wrong? What's the
Huh.
problem? And he said, "A lot of your patients are suicidal." And I was like, "Huh?" I was like,
That's why they're
"Oh,
here. Yeah,
so there's this,
yeah.
yeah." So
It-
working with the severely mentally ill patients, how do you, as a clinician, bear the risk that, people do kill themselves, they do have
mhm.
bad
Yeah,
outcomes. How do you deal with that?
yeah, yeah. Uh, um,
People
Still
die.
working on the answer in part, but I think one of the reasons I was attracted to this specialty is that, like, frankly, it made me mad that so many providers wouldn't serve the full population of folks who need mental health services. I, I think that no matter what folks are experiencing, whether they're having symptoms of psychosis or suicidality or whatever it is, people deserve ambitious psychotherapy. And if providers don't go into those specialties, who's going to help them? Um,
So can I ask you a
in
personal
terms of,
question? Can I ask you a personal question
yeah,
about how do you think growing up with a surgeon dad may have
mm,
influenced your ability to, or your willingness to handle the risk that goes along with the work that you do? You know what I
yeah,
mean?
I think it's
I mean, you
certainly,
you you got to be able to deal with the risk when you go in the operating room because people die, right?
yeah,
And you make
yeah,
mistakes.
yeah. I think it really did, particularly because the type of specialty he's in, often he's sort of the end of the line guy. Like people who see him are really sick.
Yeah,
And I mean, there would be times growing up where I'd come home from school and usually he'd, be working late, come home
okay.
6, 7, and he'd already be home when I got home from school. And, my parents explained it to me in sort of a kid-friendly way, but the sentiment was, oh, the person was too sick to help. Like they'd open them up for surgery and the cancer had spread. And I think I saw him model himself, like reckoning with that and knowing that these people need a doctor and there's limits to what we can do.
Yeah.
And this is part of what I've really appreciated about the being on the comprehensive DBT team at Stanford and how DBT thinks about and talks about suicidality in general.
Well,
And
tell us a
that,
little bit about that.
yeah, well, but part of the core philosophy is if anyone on the team loses a patient to suicide, it's considered that the whole team has lost a patient. So if somebody asks you, have you ever lost a patient to suicide, and somebody else on your team has, your answer is yes. So
Wow.
the holding it as a team is really meaningful.
Yeah.
And this idea that there's a lot we can do to help people, and I think then should do. Like there are a lot of treatments now for severe depression and other things that might feed into suicidality. I really like that one of the premises of DBT is helping people to create a life that feels worth living, and that even though that might entail pain and suffering, it can feel worth living nonetheless. And like, I'll say I have lost a patient to suicide during my postdoctoral fellowship. And it's also become an area of interest of mine in that there were sort of like standardized protocols, and I had a lot of really supportive colleagues, like a wild number of people who came out of the woodwork and were like, this has happened to me. I've been through this. How can I support you? But there's our field actually doesn't know much about what to do in terms of postvention or what happens after a death by
Yeah.
suicide. And so I'm working with a lovely student at this time who's writing her dissertation on postvention. And sort of our question is, what can happen in those moments? Because I think people will be more willing to go into this type of
Yeah. Yeah.
specialty if there's the appropriate supports. And the medical side has done a better job at this than us because I think there's more, maybe less denial around the fact that people will die from cancer or whatever.
I
Uh,
from psychiatric disorder. So I want to circle back and unpack something that you
mm,
said, which is to underscore the importance of a team approach. I remember
yeah.
when I was doing some research on some of the what makes various psychotherapies, what are like the active ingredients. And I remember one thing that stood out for me when I was looking at DBT was that the one of the main ingredients of
Mhm.
DBT is actually the team approach.
Yeah. The consultation group.
Yes. And
Hmm.
so I am a true believer
Yeah.
the importance and the power of a team approach. Whether I'm in an outpatient practice, private
Hmm.
practice, but I still have a team. I have people that I sometimes call every day, multiple times, and we dialogue and we talk, and the patients mostly love it because
Hmm.
they feel like there's more than one person that's interested in them,
Yeah.
talking about them. And then if something happens, like a suicide, you're not
Hmm.
alone in it.
Yeah,
And so that I think is so critical to working with the more severely mentally ill,
certainly. Yeah. And
high risk patient.
certainly. And I think both my outpatient teams and being in the early psychosis clinic and our DBT clinic, the team approach is major. I mean, we have a team meeting every week, but on top of that, almost every single patient in those clinics has more than one provider, an individual therapist and a group therapist, and maybe a psychiatrist, maybe a social worker or case manager. So there's multiple team members helping to hold them and support
Yeah.
them. Um,
And I
and
think
the
that's
consultation piece is major.
and I think that's one of the factors that inoculates us
Yeah.
from burnout.
Yeah. Hmm. I think very, very much so. Inoculates us from burnout. And when something overwhelming, upsetting, distressing happens, helps with the recovery and coming back from that.
Yes.
So both preventative and reactive, both.
So can I switch
Mhm.
topics here a little bit and here I would love to hear, and I'm sure our viewers would love to hear more about like if you could kind of take us through
Mm,
what the um, like the fundamentals
mm,
from your experience and your training of working with severely mentally ill patients are. Like if you could just
mm.
kind of give us a sort of a almost a TED
Yeah.
talk on what you
Yeah.
know, like what you've discerned, what you learned, what you experienced working with people who have
Mhm.
severe mental illness.
Mm. That's an excellent and hard question. I'll give you my best thoughts. I think, unsurprisingly, it really boils down to the relationship.
Okay.
Often, folks who are experiencing really severe mental illness end up feeling quite isolated, ostracized,
Lies.
forgotten, not taken seriously, stigmatized. And so the relationship is crucial and it in itself quite important in
So
healing.
how do you engage them?
Think this is where the creativity piece comes in. It is not always just sitting down in an office together and trying to talk. Sometimes, I mean, the days I'm on our inpatient unit, I can really get my steps in because sometimes I'm just walking up and down the hallway
Yeah.
with with somebody who's on the unit, having a little bit of a conversation with them. Sometimes it's doing more of a hands-on activity together that then can lead to establishing some rapport.
So it's
But
like trying to meet them where they are. We were talking a little bit
yeah.
before we start the broadcast about
Mm,
my daughter Elizabeth, who works in a inpatient psychiatric unit with the
mhm,
kind of patients that you work with,
mhm.
and the creativity that I think,
Yeah.
like, how do you like some of the groups that she does are like doing nails for women,
Yeah. Yeah.
in a space where they're engaged in an activity, and she's I haven't seen the groups, but she said they just start
Yeah.
talking,
Yeah.
and so the creativity is important, and
Yeah.
but and
And
meeting the person where they are, like,
mhm.
and what else?
Eh,
What else about the like what you know about the engagement
yeah.
process?
It sounds overly simplified, but what I always think to myself and what I tell trainees who I'm working with is like, just be a human, be a normal human. You don't like if you come in there with your psycho babble jargon or really have an agenda or trying to teach them a
Oh,
skill. So some people really want that and it works well, but a lot of people will be like, whoa, 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 I
yeah, yeah.
know.
So
And
the
so,
self of the therapist have this self.
yeah,
So how do you do it? Like how do you do it?
yeah. I think one of the things I like to do on the inpatient unit is um I think coming from my interior designer mother, like I like clothing and fashion and like bright colors and accessories and usually will wear something that's like a little funky or very colorful and oftentimes patients will comment on something and then it's nice to strike up a conversation. Like today, I was just wearing good old Reebok sneakers,
Uh-huh. Uh-huh.
and there's a woman on the unit who always has the best sneakers. She's been admitted several times over the years, and like every time I see her, she has a new cool pair of sneakers. And she came up to me and was like, "Dr. Adams, Reeboks are the best." And she'd been having a really hard day, but then we started talking about sneakers and shoes, and it launched into a really lovely conversation.
So though, so taking advantage of those moments of
Yeah.
mutuality and connection, you're saying is like
Yeah.
critical. All right,
Yes.
that is helpful. What else would you say? So we're talking about like engaging them,
Hmm.
being your just being yourself, not
Yeah.
not hiding behind your professional
Hmm.
facade. And what else do you
I
do?
think too, just the deep attentiveness. Most people
Yes.
truly have not been listened to. And,
Absolutely. Absolutely.
and
You know, we interviewed Laura Brown, who, as you know, probably knows one of the leading people in trauma therapy. And
yeah,
she, in her interview, and we wrote this down and we teach it, is she says, listen as your life depends upon it.
that is a great quote. Yeah.
And I think that's what you're saying.
Yeah.
Like people are not used to being attuned and listened to.
And in the hospital too, right? When I go in a patient's room, they're like in a hospital bed, et cetera. And it's very easy to sort of stand there and be awkwardly like looming over them. And it's nothing fancy, but like get a chair, sit down, put your clipboard down or whatever. And
Do you touch?
usually not in the general hospital policy, but if a patient expresses the desire to, like, I'm good with a fist bump or a handshake or a high five.
Ever hold someone's hand?
Sometimes on rare occasion, but sometimes. I think usually if I know somebody a bit better and it feels like a informed intervention, then yes, if they're a lot of the people, it's really the first time I'm meeting them, so am more reticent, just because I don't know what it might mean to them or bring up for them. Um, but yeah, like being attentive, listening. A lot of folks too either are so scared, even paranoid, so depressed, anxious, whatever, that there can be a long latency. And so
Mhm.
sometimes I will literally bring a clipboard and a piece of paper and ask them a question and be like, I'm gonna like write down some thoughts to myself of things I need to do later. You take your time thinking about it and just let me know when you want to pick up the conversation. And I'll sort of sit and be in the area with them, and usually they just need a few minutes to either gather their thoughts, or if there is thought blocking or speech latency happening, they just need time.
So your presence is what you're saying, like just being present,
Yeah.
not feeling like you have to fill up the space with like
Yeah.
so managing your own anxiety sounds really important. Like
Mhm.
you don't need to be directive, you don't need to come out, you just need to be present, it's
Yeah.
open.
I think so. And uh, often, again, people can totally take in information and learn skills and leave the hospital with really good information. And oftentimes, at least at first, folks are in so much distress that understandably they can't take in a lot of info. They take in the feel, the vibe, the presence.
Okay,
And
before we get to the next step in your
yeah.
treatment, do you think that psychosis in itself is traumatogenic? Like people that have psychotic episodes are traumatized I
Mm.
mean, they also suffer from PTSD
Yeah.
from having a psychotic or schizophrenic
Mm.
episode.
Yeah, this is a good question. I think there's like a lot of research being done currently on this, and it's very much a new part of the field, but at this point, like there's pretty solid suspicion or hypotheses that if you experience trauma, it's maybe more likely that you'll later experience symptoms of psychosis. And also, a lot of people do experience psychosis itself as traumatizing and scary and upsetting. And so then in therapy, you're addressing all of that. Like
But isn't the treatment oftentimes traumatogenic for people? Like being, sometimes my patients are sent to the hospital against their will in ambulance, and
yeah, yeah,
sometimes in my area, they will sit in the emergency room for 12 hours or in a
yeah,
holding unit with very disturbed. So
yeah.
I get patients when they come back from the hospital, I've got to treat the trauma from the treatment.
Yes. Yeah. I think particularly involuntary hospitalization is often experienced as traumatic. I mean, for anyone being hospitalized against your will, being given medications that you don't want or don't understand. Some some patients might have court-ordered ECT. Like these are scary, traumatic treatments that we might deem medically necessary and might ultimately be helpful, but the experience is terrifying. And there's, I don't actually know if it's officially published yet, but there's some interesting research happening in the Pennsylvania area where they have pulled data from different counties and are looking at folks who were involuntarily hospitalized, the people who were kind of just on the cusp, like it could have gone either way of being hospitalized or discharged. Folks who were just on the cusp and were involuntarily hospitalized, there were actually a lot of negative outcome effects seen down the road, which I think is not surprising. And again, that's like research literally happening as we speak. So I don't know fully how it'll shake out, but
So getting back to your how you do the work. So it
mm,
sounds like that the safe creating a safe
hmm
um, space. And
hmm
we're talking about how like you're not like pressuring the person to
yeah,
answer questions, and you're trying to enter into a space with them that they can
hmm
feel you're safe.
hmm yeah. Again, that if I do nothing else for someone at the hospital, then leave the idea in their mind that talking to another therapist might be helpful in the future, like that's a great success
Yeah.
because people will
Yes.
probably only be there for a few days or a couple weeks. It's really setting them up for
Hopefully
success.
they'll remember that and
Yeah.
they can draw from that. All right. So what next?
So what next?
So
I think,
you enter their space,
yeah.
you create a safe holding space for them
Mhm.
through your therapeutic self, right?
Yeah.
And then how do you help a psychotic person?
I think this is where I am a huge proponent of people in our field having to really master good case conceptualization and why,
Oh, wow. Tell us about that.
yeah, why is why I'm drawn to integrative psychotherapy approaches, common mechanisms of change, because no two people are going to be exactly alike, right? When
So
I
you
hear
don't
about,
just go by the diagnosis. You are interested
yeah,
in trying to formulate
exactly.
phenomenology, the symptoms, the whole complex into
Mhm.
some coherent.
Yeah, yeah. And I think the sort of best summary I've heard is I really like Michael Garrett's work, where he wrote a book about integrating CBT for psychosis and psychodynamic psychotherapy. And his thesis statement is basically CBT can help people see the quote unquote literal falsity in their thinking. And psychodynamic therapy can help them understand the figurative truth.
Oh,
I think that that's so beautiful because in the
mm.
conceptualization, you can say, like, okay, what particular symptoms or stressing experiences is this person having? And then the treatment's going to be quite tailored to that.
Can you give us an example, like of a conceptualization of a patient that you worked with recently?
Yeah, I've been working with a gentleman for about 2 years now who was on the inpatient unit and then was discharged, and I saw him on the outpatient side too, and we've been doing weekly individual therapy. And when he was at the hospital and when we started outpatient work, his sort of not his presenting concern that he would state, but that his providers would state is that he thought he was Jesus. He thought he was the second coming of Christ. He's here for revelations to unfold.
So
And as
delusional thinking.
and as you might imagine, this was interrupting his ability to engage in life in various ways. And my conceptualization was, as I learned more about him, he'd had a lot of sort of subtle trauma throughout his earlier life, nothing overt, but grew up in a very high functioning family, a very wealthy family. Everybody had a good job, was successful. And when he got to later high school, he started to struggle and ended up dropping out of college and is a very smart guy, but was sort of this failure to launch kind of presentation. And then later went on to develop overt symptoms of psychosis, but had to leave college, lost his friends, people started distancing themselves from him. And I think he
More and
really,
more isolation.
yes, and I think he really developed this profound worry that like he was a loser, I think is how it would be summarized in his mind.
So
And
his deep code was, I'm a loser.
yes, and thinking you're the Messiah is actually a very brilliant anecdote to thinking you're a loser, right? Like it in his mind totally propped up his self-esteem, gave him a sense of purpose. Like he was actually quite happy for a period of time with that line of thought.
That's interesting. I think that's what Dick Schwartz would call a protector self part, right?
Yes.
It's a protector against his
Yeah. Yeah.
deep-seated sense of being a loser and inadequacy that
Yeah. Yeah.
protector part said, no, you're Jesus Christ.
Yeah. And so in our work together, I was like, I'm not going to touch the delusion at first. I'm not going to challenge it. Instead, let me see like the other areas of life causing pain. And since we've been working together, he's working full time now. He adopted two pets. He's moved into his own apartment.
Oh,
Like he's started doing other things that I think in the background, there's no longer that same worry, I'm a loser. Like he's
he's
doing
actually
and
functioning well.
and as those things have happened, he came into session maybe a year and a half into our work and was like, I actually like I don't think I am a messiah. And I was like, tell me more about that.
Oh,
And
so you're saying that you didn't try to talk him out of his delusion. You let him keep it, and
yeah,
you tried to understand him to why he would have adopted that
yeah, yeah,
protector part.
yeah. And there's still certainly oddities in his thinking and other things, but
He's functioning.
the necessity of the belief, it became less necessary. And then there was a period where he was much more depressed because coming to terms with being an average Joe was kind of depressing. But we were able to then talk about what does that mean? What next? Um,
Interesting. I have a question from
yes.
one of our viewers. Is it safe as a private practice outpatient clinician to take a psychotic patient if they are stable?
In general, I think yes. And this is a really good question because I think it is one of the reasons that folks with psychosis have trouble accessing care. The vast majority of folks who have symptoms of psychosis are lovely, delightful, totally safe people. And sometimes when there is a more intense level of paranoia, like when any of us feel paranoid, we get really scared. And sometimes from a place of fear, people then might do something that in their mind is protecting themselves, but could potentially put a provider in danger. This happened on our inpatient unit, which you would not be seeing somebody like this in private practice, but somebody had the thought that the providers were trying to steal their eyes. And a provider didn't know this. They were new on the unit and went in the patient's room just to, bring them something. And the patient got really scared and pushed the provider away because they thought they were trying to steal their eye. If I thought somebody was trying to steal my eyes, I would also push them away. So I think being on the lookout for higher levels of paranoia and potential
Or impulse
defensive
control.
self-protective behaviors that could become aggressive would be my main worry.
I know there's a lot of stigma associated, especially in the, if you look like
Mm,
in the media, there's a lot of unfortunately a lot of emphasis being placed on like the mentally ill or violent. Can you just tell us a little
yeah,
bit about what you know about the like
I
this
think
is
it's largely misconstrued. Uh, I mean, I think sometimes folks who are experiencing mental illness can do violent things, and I think many violent acts are committed by people without psychosis or whatever diagnosis. Um,
so there's not necessarily a higher incidence of
I don't
violence
think
in
so. I
people with
don't,
severe mental
yeah.
illness.
As far
I
as
mean,
I'm aware, I don't think there's actually solid data to support that. I think it's a little bit like when there's a shark attack, it makes the news
yeah, yeah, yeah.
and then it's like on everybody's mind, but it's actually very rare.
All right, so let's get back. I love what you're what you're teaching us now. So the first step is you create the safe space. You
Mm,
approach the person as a real human, that you're a real human being that's there,
mm,
present with them and open to them and attuned
yeah.
to them. And as you're getting data, you're starting to have a case formulation, which is going to guide
Mm,
your treatment.
mhm.
What do you do next? Once
I
you have
think
your case
next it,
formulation, what do you do?
yeah, I guess it depends on your formulation.
Right?
So when I'm working with folks with psychosis, usually it is more cognitive behavioral techniques up front, either because folks are having more negative symptoms and need a lot of like behavioral activation,
So
just like,
tell me what you mean. Tell our viewers what you mean
hmm,
about negative
yeah,
symptoms.
in psychosis, there's both positive and negative symptoms, and it's just like math, where you're either adding something to the quote unquote normal human experience or subtracting something. So, negative symptoms could be like slower movement or lack of movement, poverty of speech or very slowed speech, very dulled emotions or a sense of emptiness, sometimes even like thinking feels slow. So that there's something most people experience that is either very dulled or absent. And then positive experiences like you're adding in something like maybe hearing voices or something there's like a new experience that's showing up.
Okay.
And so medication is pretty good at treating a lot of the positive symptoms but not so good at treating the negative symptoms, and behavioral activation techniques or getting just people like up and re-engaged in the world can be really important. Getting more social connection can be really
How do
important.
you do that?
Again, depends on precisely why the person is less
Disengage.
engaged. Sometimes it's more social anxiety related. Sometimes it's just side effects of their medication, which is maybe really sedating. Sometimes it might be that they're feeling hopeless or depressed by a diagnosis and have gotten in a pattern of staying at home and staying in bed, and it's sort of the cycle of depression has unfolded and you just have to like start doing stuff again to start to feel better. So it's varied, but yeah, usually sort of CBT techniques that are adapted for psychosis are a great first place to start. Um, but there's a whole variety of therapies. A lot of therapies are, I think, still helpful to folks with psychosis. They just either need to be slowed down a bit, or as providers, we need to be more thoughtful about how to tailor them. But at the core, a lot of it's the same.
How important is the continuity of the relationship with the therapist? Because I know that in a lot of
Yeah.
institutions, residents come in every 6 months as a new resident, and I have patients say,
Yeah.
I just started to form a relationship with someone, and a new resident comes in, and
Mm,
how important is that to the
mm,
the healing process to have a like
Yeah.
someone who's with them, inpatient, outpatient, and follows them over the course
Yeah.
of time.
I think it is important. I don't know if it is essential and that good stuff can't happen if that's not the setup, but it's helpful. And one of the things I've appreciated about Stanford is a lot of the people who work on the inpatient team at the hospital also work in the outpatient psychosis
They're
clinic.
able to follow the patients. So the
Sometimes,
continuity of care
yeah.
sounds
Yeah.
like that
It,
having that stable relationship with an attachment figure.
yeah. And even if the like literal same provider doesn't see them in both inpatient and outpatient, they're part of the team. And
uh,
so, and usually the patient's aware of that. And so there's
an alliance that's built with the team.
yeah, with the team, and there's a more solid like handoff between team members. Yeah, allows for a really smooth transition of care.
And so, okay, so now we're in treatment. And how do you, like when people that you're working with start to decompensate or act out, how do you handle
Mhm.
that? Because that's always a
Yeah,
part of working with the severely
yeah.
mentally ill. They have tough times and they act out or they decompensate.
Mm.
How do you address that in
Yeah.
work?
Again, classic therapist answer of it depends, but I generally try really hard to keep people out of the hospital if at all
Yeah.
possible. Like there are of course times when people do need to go to the hospital and
Yes.
benefit from it. And it can be really disruptive to continuity of care if somebody's bouncing back and forth between inpatient and outpatient. So I feel I've been very lucky to have I think the necessary training to largely feel comfortable still supporting people outpatient, of course with the support of my larger team to a fair extent and can keep doing the longer term work. And there are moments where if I'm not confident that the person's going to be able to remain safe until our next session at minimum, I will have a serious conversation with them about thinking through hospitalization. Um, I, knock on wood, have thus far never had to involuntarily hospitalize somebody. I think because the folks I work with know that I treat that as a last resort and am very thoughtful about it. When I have suggested it, people have gone to the hospital. And then it's been a much better experience from the start, too, because they're voluntarily admitting themselves. They know what their goal is in the hospital treatment. Um, but yeah, the specific way it gets managed really depends on what's going
Well,
on.
one of the things that I've noticed in my practice is that in the community that I'm in is that it seems like there's a much lower tolerance for anybody that is um, showing any signs of
Mm.
psychoses. I'm finding that
Mhm.
very quickly people say go to the emergency room, and then
Yes.
and then I wind up feeling like I have to then treat the trauma of having
Yeah.
having spent time or being paid. And I don't know if you notice that in your community or not. You're on the West
Mhm.
Coast, I'm on the East Coast. Um,
Yeah.
it's very disconcerting that school systems and even practitioners sometimes, especially a phenomenon that I've been noticing is that many of the practitioners who primarily do telehealth and aren't in the same community, some
Yeah.
start having suicidal ideation. They go to your emergency room, and it's like, oh, how,
Yeah. In my mind, I'm like, please don't do that.
yeah, have you noticed that too?
Yes, I think, and again, there's a lot of factors that I believe play into this, but I think as a field, we can be overly alarmist in a way that's
Yeah.
ultimately unhelpful.
Yes.
I think a big part of that is the systems in which we work, including like a larger society where litigation is alive and well.
Yeah.
A lot of, like, on one hand, providers have good reason to feel nervous, and when we end up practicing in systems that prioritize making sure that we're not liable or have sort of like covered our bases in terms of liability, it can get in the way of what's actually most effective care.
Yeah.
Like,
And it seems like we aren't doing a really good job of looking at the harm benefit sort of
yeah,
vision analytics. Like, it's great if someone starts talking about suicidal ideation, say, oh, go to the hospital, then I can sleep tonight
yeah,
better. And then, when they get out, we can put them in an intensive outpatient but it just seems like we're abdicating our,
yeah.
like, I
And
keep
that,
thinking about your dad, like if he said, oh my God, this person might die in the operating table. I'm just not going in the room.
yeah, yeah, exactly. It ends up, I mean, providers really get caught in the middle because it's like, oh my gosh, I could try to help this person, but then am I gonna get sued if something happens?
Yeah,
Oh my,
yeah,
of course, who would be able to sleep well at night? And that seriously interrupts good patient care in that, like, people certainly can feel less suicidal at the hospital or maybe do get on a medication that really reduces suicidality or gets another intervention. But for most people, going back to the DBT framework, like usually people feel suicidal for a reason. Something about life feels unbearable, and there's not enough other stuff to make it feel worth living
yeah.
despite the unbearable thing. And that's going to take longer term outpatient therapy to
Yes,
untangle.
yes. And so how do you deal with the anxiety of working with
Mm.
ill patients? Like, personally,
Yeah.
how do you,
Yeah. I think a big part's being on teams and
know,
being on really excellent teams. I both
having people
admire.
who are confident that you feel that you
Yeah,
can trust, and that,
yeah, I appreciate my teammates in that they're all exceptionally competent clinicians, but also just delightful people. So they're supportive on both fronts in terms of like technically what do I do and also like emotionally what do I need. Um, it is helpful working within a larger institution. Like I certainly see clients at Stanford who I would not see in private practice because I don't have that team and I don't have the ability to phone a friend on the inpatient unit or whatever to say, I'm sending this person to you. They need something more than I can give in this context. And I also I have found that a lot of the folks I work with sort of know, like they've had other therapists refer them out or bounce them around. And part of my intake process is sort of explaining to them that I think we need to be able to do depth-oriented work. And for us to be able to do that, I need for them to be alive. And can they take suicidality off the table for a period of time or whatever it is? And a lot of people actually like are amenable to that. Not always at first or not always for a particularly long period of time, but I think most people understand like we've got to let the treatment work. We need to get you an effective dose, and that can create the space to really get
Hmm,
into it. And I also talk to people about that I do work at the hospital and in the outpatient department, and that I usually use different language with patients, but will explain that I am not a provider who's really alarmist. And if they do tell me that they're having thoughts of suicide, I'm not going to immediately send them to the hospital. I'm going to want to
yeah,
really know
yes, yeah.
more.
I do the same thing. I reassure people, like, you can
Yeah.
talk to me about your suicidal thoughts and ideation or even impulses, and I'm
Yeah.
not gonna skip you off to the hospital. I mean, I'll do something if I think you're an imminent risk to yourself
Yeah.
or other
Yeah.
people. But you can tell me how one of our viewers said, but patients in the hospital, I'm sure, sign risk of death kind of uh, forms, like, the surgery has high risk or whatever.
Mm.
Maybe mental health professionals need that protection too. Maybe
Mm,
I think what Diane's suggesting is maybe that
mm,
we should have something similar in mental health, that like there there's risk, and
mm,
the other thing is that there can
mm,
be harm. As I mean, 40% from the statistics that I have been looking at of us
mm.
harm at times. That's a
Yeah,
lot.
I think that that is something we don't like to reckon with as providers,
Yes. Yeah.
and is is one of the parts that's really hard about working on the inpatient units. I love it, and part of me is like a little abolitionist in that I think we need to like totally break apart and redesign the system in terms of how inpatient hospitalization goes. I
How
think
would you do it?
that's a great question. I think a big part of it comes down to actually the interventions available outside of the hospital, in that there should be many more stop gaps between somebody being admitted, right? Like often frequently people are admitted to the inpatient unit and have had no therapy services. It is their first introduction to the mental health system. And it's because they couldn't afford outpatient care, didn't know how to get connected to it, didn't have anything local, don't have insurance, whatever.
Yeah.
But the things got so bad, they wound up at the hospital when it was probably a long time coming. There's also not, as I mentioned earlier, that they certainly exist, but there's not a ton of sort of mid-level types of
Yes. Yeah.
care. And I think too, like the general public doesn't know a lot about them. You know, I think a lot of people think of therapy and they think that you go to your shrink's office for an hour a week or whatever. And
Well,
there's just,
one of the things that really surprises me is how few clinicians actually will intensify the therapy when,
Mhm.
so like if I have a patient who is
Mm.
having a difficult time or suicidal, say, just come in more, and I'll make time to see the person, and
Mm.
I'll see them. And usually, like if someone's having a really severe crisis, if I offer to see them more frequently, we can get through it. But
Yeah.
so many clinicians now are, oh my God, go to the hospital. And I really have a hard time with how easily we tend
Mm.
to move in
Yeah.
that direction. Like even
Yeah.
when you
Yeah.
call people, if you're having an emergency, go to your hospital. Like, well,
Mhm.
how about coming in for another session and figuring out
Yeah.
what's going on?
Again, speaking to that, like there's so many middle options. And I think you're right. I guess I will say with a caveat, I largely agree with yes, often if people have an extra session or a few extra sessions, if it's a distinct period of higher distress, they can get through it. The part of me that's the caveat is one of the tenets of DBT is often actually the frequency of sessions might increase as the person's starting to improve, in that and our mental health systems can do this broadly, that sometimes the only way people can get care or get attention or get someone to listen
Yeah,
is
yeah,
through an escalation, and that can
that's
inevitably get reinforced
that's
in an
really
unhelpful way.
well, that's really sad. I mean, I think if we could,
Yeah.
I mean, there are so many factors that affect how we administer treatment, how treatment is provided. I mean, there are not
Hmm.
enough therapists, there are not enough well-trained therapists to do the work,
Mm.
and then there are limited resources, and it creates a real crisis in our mental
Yeah.
health system. We could do so much more
Yeah.
on an outpatient basis with even the severely mentally ill patients if we had like if you're having a hard time, call and we'll get you in.
We have good treatments. Good
Right.
things exist.
Yes.
Yeah.
So we have about a minute left.
Okay.
It's, time is going so fast. This has been so interesting. What would you say to early career clinicians who
Mhm.
are going into this field about the appeal or the gratification of working with severely mentally ill patients?
I mean, obviously, I love it. I think that there's a lot of
I can
appeal.
tell you're passionate about your work, and I bet your patients just love having you as their therapist.
I hope so. I think the thing I've appreciated is the wins are big. Like it's so gratifying to see somebody like meeting them at one of the most painful times of their life start to come out of that is huge. Like it's major cause for celebration and it's unfailingly exciting and fulfilling and meaningful and it is never boring. It's always a new adventure, a new something to think through, a new problem to solve, a new person to work with. It's fun.
Dr. Connor Adams, thank you so much for sharing your expertise with us. This was really interesting, and sharing your passion with us, I hope, will inspire other people to do this work. We hope you come back again another time. And thank all our viewers for watching. The recorded version will be up shortly. So thank you all, and have a good night to all of you.